The Jerry Pal podcast is brought to you by Archstone Foundation, preparing society and meeting the needs of an aging population. And now, here are your hosts.
Welcome to the Jerry Pal podcast. This is Eric Cordero.
This is Alex Smith.
And Alex, who do we have on Skype today?
On Skype today, we have Anand Iyer, who is assistant professor at the University of Alabama at Birmingham, who is in the Division of Pulmonary, Allergy, and Critical Care. He also has an appointment in the Center for Palliative Care at UAB, and he is the founder of
Hashtag Pallipalm.
Hashtag Pallipalm. We will talk more about that.
So before we talk about Hashtag Pallipalm,
welcome to the Jerry Pal podcast.
Welcome. Do you have a song request for Alex?
Yeah, it's probably your first person from Alabama. I got to choose a song that came out of Muscle Shoals. Hopefully your audience knows about Muscle Shoals. Probably every hit from the 60s came out of there, the same recording studio.
Never heard of it before.
Yeah, you got to Google it. So Aretha Franklin, Lynyrd Skynyrd, Rolling Stones, everybody recorded there. So Land of a Thousand Dances by Wilson Pickett. Let me see what you got.
All right. Gotta know how to pony, like a bony Maroney. Mashed potato, do the alligator. Put your hands on your hips, let your backbone slip. Do the Watusi, like my little Lucy. Na 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 na. I need somebody help me out just one more time. Come on now. Na 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 na. Yeah. All right.
Yeah, awesome.
That is a jam.
That is a jam. That'll get your 2-year-old dancing right there.
That's a fun one.
That was awesome. I got the energy now. I don't even need coffee.
That's right.
So, Pallipalm. What the heck is Pallipalm? Is that a type of berry?
Yeah. Pallipalm's an online community I started last year of clinicians, investigators, patients, and caregivers to bring palliative care to people with chronic respiratory disease. And now it's grown to be something worldwide. But if you're a fan of Star Wars, I think Pallipalm is more of a higher state of being. It's where you can bring the best of both disciplines into one person. So palliative care and pulmonary medicine. It's a good side of the force.
I love it.
Wait, that was an analogy about like bringing together the good side and the dark side into one person or something like that?
Now, I don't know about pulmonary being the dark side, but
I know, I was going to ask which is the light, which is the dark. That's good. That's good.
And you've written a lot about this, and it focused a lot on COPD. How did you get interested in this as like a topic?
well, like everything, it starts at the bedside. You know, you could care for patients as a resident. We've all probably admitted dozens, if not hundreds, of patients with COPD exacerbations in the hospital or seen them in clinic, and find out that they have a lot of needs, not only extending for their own, but to their family members. And as a fellow, I did more of that and saw that those needs were huge. And I was the one that was intubating them. And so over and over and over, and to a point where that gets to you psychologically, where you're like, what's going on here? They don't know what's happening in their disease course, and their utilization is high, and coming to the hospital over and over. Plus, they just have a really poor quality of life near the end of their lives. And they could really use palliative care, but we're never getting it. So I started out made that a research career. A lot of my initial research was very clinical in things like pulmonary artery enlargement and Medicare samples, but I'm shifted into how does palliative care fit into this picture in the last few years.
And I can imagine there's a kind of an analogy with heart failure in palliative care. In one way, like when we think about heart failure specialists, some of the best symptomatic management for dyspnea and heart failure is really good heart failure management. And I could see, like, for the same thing, like some of the best ways to treat dyspnea in COPD is really good COPD management. So when we think about the needs for these patients, if we just focus on really good pulmonary care of their COPD to treat their dyspnea, like, do you really need another specialist involved in their care? Do we have all the needs met?
Big answer is no, we don't. Dyspnea is just one piece of the puzzle. Yes, it's one of the biggest pieces, but so is depression, anxiety, an inability to cope, and prognostic awareness. These are all themes that I've discovered in my own research, but those extend to the patient and their caregivers. So there's a lot to offer from not only palliative care, but geriatrics in the broader scope.
Yeah. Well, let's talk about some of your research. So you did a study in Annals of ATS, American Thoracic Society, looking at some of the needs for patients and family members. Do you want to describe a little bit about kind of what you did there and what you found?
Yeah, that was a qualitative study of patients with moderate to severe COPD and their family caregivers. We had audio recordings, semi-structured in-depth interviews, and then conducted a thematic analysis and discovered 5 major themes raised by patients and their caregivers. Those were coping with COPD, emotional symptoms, respiratory symptoms, illness understanding, and prognostic awareness. But what was unique about that study was focused in on early palliative care, and that's palliative care long before the end of life. Patients and their caregivers universally accepted the concept, although they had almost never heard of it. And these 5 themes of needs were shared across disease severity. So it wasn't just something, which is currently happening, that you should wait until the end of life to do. Rather, you could start incorporating it in less severe COPD. And that's been the whole crux of my research the last 2 years. Don't wait till they're on the vent in the ICU to start palliative care.
And when you talk about early palliative care, what were you talking about there? Were you talking about early identification of palliative care needs and having like primary palliative care where people are addressing those needs? Or is it early palliative care in COPD where you're getting early specialist level palliative care for these individuals with COPD?
Great question. I mean, I have as one of my mentors, Maria Bakaitis, who sort of helped to bring about this field of early palliative care in oncology. And, that's at the time of diagnosis in advanced cancer. So that's a little bit trickier. It's hard to say you can do early palliative care in the diagnosis of COPD. But you would want a pulmonologist or a primary care clinician to have a basic set of primary palliative care and geriatric skill set to start the process of whenever they see a patient, whether that's at moderate, severe COPD or even milder stages, to recognize that they need to start initiating something. And then when things get a little bit tougher, refer over. There are plenty of figures from CAPC and other organizations that illustrate this nicely. The amount of the dose of Geri-Pal gets to be more and more as that person gets closer and closer to the end of life.
And in the study and in talking with patients and family members, was there anything that surprised you as far as their needs?
Well, I think the coping one was just brought up so much. They didn't have an idea of what to do with their illness, like how to do things. One guy just talked about it took him all morning just to bring up the energy and the will to go and empty his dog water bowl for his dog. And so he talked about that was his primary focus for the day, was just to get over there, change his water bowl for his dog. And I thought, okay, well, that's incredible. That's a lot of social isolation. There's a lot of depression there. There's a lot of, physical mobility issues. How can we get his strength up? And I started thinking about all these things that I could do for an intervention that could help him just do that. And that could make so much better quality of life for him. But everybody sort of echoed this. And then what we never do as pulmonologists is reach out to the caregivers, hardly ever. And they were bringing up all the same things for themselves. When COPD was diagnosed in my loved one, their mood changed. They started getting angry. I didn't know what to do with them. I was scared. I never left the house. I became socially isolated myself and fearful and anxious. I wish I could give them a can of air, somebody said. So they were starting to express a lot of anxiety. And I'd seen it but they were telling it to me, and I had exemplary quotes in the paper, which were just fascinating.
Mm-hmm. You know, you mentioned anxiety here, and one of the key themes that you describe are emotional issues. When I think about the patients I've seen with COPD, anxiety does seem to come to the fore more so than depression, and I wonder if that's part of the physical manifestations of the illness itself. Being short of breath is a state that causes anxiety in many people. I wonder if that is borne out in your research.
Yeah, that's for sure. I mean, it's like drawing back to Maslow's hierarchy. I mean, you've got to try to think about survival, and you're going to be very anxious when you can't breathe. So yeah, there's a vicious cycle there that perpetuates itself. And I think that there is often even a phenotype because these people have smoked their whole life. And so smoking, anxiety, depression are all intricately tied together, and self-medicate by smoking, and so depression exists in COPD, and so I wouldn't forget about that also.
All right, so we have these palliative care needs, these needs for early palliative care in these individuals. So just going to restate them: coping with COPD, emotional symptoms, respiratory symptoms, illness understanding, and prognostic awareness. What did you do next in your kind of research on this topic?
So simultaneously, I was also interviewing clinicians from palliative care and pulmonary medicine to get their take on early palliative care. And that was pretty eye-opening. If you're going to try to design any system-level intervention or interventions at all, you need to be able to understand what the frontline clinicians are thinking about the field. And that was pretty interesting because we did a qualitative study where we interviewed pulmonary critical care clinicians and palliative care clinicians about early palliative care and COPD, and found a lot of barriers and facilitators to bringing early palliative care to this patient population. They were in themes of like educational themes, clinical themes, and operational themes. Those are the three big categories. But fundamentally, pulmonologists were, like they do in cancer, and like people do in oncology, didn't get the term palliative care correct.
How so?
Yeah.
I mean, it was fundamentally interchanged over and over through the interview. It was only useful for end-of-life care. And it was often switched with hospice back and forth.
So it was synonymous with hospice and end-of-life care.
Yeah, you probably heard that, Jazz, too much.
Yep, that sounds familiar. Yep.
But it's more fascinating because pulmonary critical care, we work with palliative care clinicians all the time in the ICU. So I was expecting to have some semblance of, what this is, guys. But the critical care clinicians are trained to bring people back from the brink of death. It's part of our core. We're trained to intubate, to shock, to resuscitate. So that's where I started to have that pally-pulm concept, is somebody that can look at that person and think she's 88, 92 years old with pneumonia, respiratory failure. I can intubate. I can use high-flow nasal cannula. I can think about opioid morphine for dyspnea. I can start thinking about other measures and a fan even. And should I do it? Should I do this? What would be best interest for her? And, that kind of thing is the power of having both in your hands is pretty cool.
Did the pulmonologist have any other concerns about palliative care?
Yeah, so then they raise the clinical stuff, like when do we refer to palliative care? Aren't they going to narc up my patients? Are they going to give them too many benzos until they have a respiratory arrest? And then how are you supposed to add palliative care stuff to our already busy clinical life? And is palliative care going to be able to handle COPD? Because the numbers are infinitely larger than cancer.
Yes, huge numbers.
Did the palliative care doctors have similar concerns, or what were their concerns, if any?
Yeah, so their concerns were close. I mean, they recognized the misconceptions that pulmonologists would see, so they knew that those existed. They too were concerned about how to manage opioids and benzos in COPD, and when would be the appropriate triggers, and how to prognosticate in COPD, and then would they have the bandwidth? So it paralleled nicely between both disciplines.
Do you want to say more about this concern about use of opioids and benzodiazepines in patients with pre-existing lung disease?
Yeah, I think it always refers to things like chronic hypercapnia and this sort of hypoventilation state, you give too much opioids to somebody in that state, you may actually cause enough respiratory suppression to precipitate a respiratory arrest. And in COPD, that could lead to hypercapnia, acute hypercapnic failure, in which case they might become somnolent, obtunded, and need to be intubated.
Can you just say what hypercapnia is for our listeners who are not?
Great point. High carbon dioxide levels. And that's what makes people sleepy, and people with COPD have high CO2 a lot, and makes them real tired, and then they can become obtunded, which point I come in and intubate. Happens all the time up here in the ICU. That's often one of the reasons for transfer.
Wait, sorry. Is one of the reasons for transfer hypercapnia, or is it opioid-related hypercapnia?
I mean, it can be opioid-related hypercapnia, or just hypercapnia from a COPD exacerbation.
So you believe that this concern about opioids leading to hypercapnia for patients with COPD, in other words, the opioid themselves slows down the respiratory rate, so that people with COPD who are at risk for building up CO2 in their bloodstream already, that's further exacerbated by the low respiratory rate, and they're not blowing off that CO2. That CO2 accumulates in their bloodstream, makes them sleepy. They are unable to protect their airway, and they're at risk for, not breathing.
Right. That's exactly right. I mean, I'm not stating it as I'm opposed to it. Rather, I think it needs to be a combined effort between a palliative care clinician and a pulmonologist working together to find the right dose that would be safe enough. And I have had patients personally who have started low-dose opioids and have had tremendous benefit in relieving their dyspnea. So it's not without question that it could help. It's just something that's a lot different clinically than someone with cancer, where you could do that a little bit more freely.
And I also want to refer to our listeners, if you want to learn more about dyspnea, both in COPD and cancer, we did a podcast about a month ago with David Currow from Australia. Really great topic. We talk a lot about the research behind this, including the evidence base for opioids and dyspnea. And I think one of the key take-homes is usually those are smaller doses of opioids given as long-acting medications. But again, I really encourage you to listen to the David Currow podcast.
But interested to hear what you use when you say low-dose opioids. What are you using?
Like oxycodone, like 5 milligrams twice a day as needed, something like that. And I'd find that won't hurt anybody.
Twice a day.
Yeah.
Though the half-life is short enough that it's like 4 to 6 hours or something.
Right.
You give it twice a day.
Yeah, I'd probably be okay with that.
Yeah. But in more than that, you might be concerned.
I'd be a little bit more concerned. But again, I'm still just starting out. So
Right. Would you ever use liquid
and then
morphine?
in the inpatient setting, I would use 2 milligrams IV morphine when I can see them in visual and watch them.
Right.
And I'd give them much more frequently.
Yeah.
And I'd observe that, and I can see it, and I'm okay with it.
And just a shout out to our listeners again. I think the one big take home from David Currow was like all the studies are long acting opioids, but they have formulations of long acting that we don't have here in the US generally, which is lower dose. So someone out there, give us a low dose, long acting formulation.
Yeah, right.
We need that. And the other take home from the David Currow podcast was that for people with moderate to severe shortness of breath who were started on long-acting opioids, there were no harms in terms of respiratory depression that rose to the level of clinical alarm.
In the studies using low dose, long-acting opioids.
Right.
So how does that convert to clinical medicine is another question.
Right.
Yeah, and I mean, and some studies have shown some adverse events in older adults in particular. Yeah. So we do have to be cautious about the opioids and benzos in that population anyway. So just keep throwing it out there.
So going back to kind of what you've learned from the palliative care doctors, the pulmonologists, was there a consensus of who should get kind of specialty level palliative care?
Yeah, probably. I mean, people gave some referral criteria, and almost all of them thought, the clinician side thought you get a certain FEV1 in the like 50%, so that would put you at around moderate or be severe to very severe COPD if you're using these staging criteria. So that's your lung function on a pulmonary function test. People who have severe shortness of breath, frequent hospitalizations became brought up as criteria. You're admitted or you get admitted to the ICU in particular. I don't know if you guys know that, but a person who's admitted for a COPD exacerbation, 1 in 4 may die in the year after that, and 1 in 2 will die within 4 years. So a severe exacerbation is a pretty sentinel event for COPD. So everything that you saw in residency and admitted, those people have a high mortality in the next year. So that's an immediate trigger for me that they probably need some palliative care at that point. Starting things like BiPAP and or having things like depression and anxiety. But the list was huge. What could be brought up, but frequent hospitalizations kept coming up over and over.
Yeah. So it sounds like part of that is from a prognosis standpoint. Their prognosis may be significantly worse. And when I think about COPD too, I think one of the challenges is prognostication. Like I can look at like the BODE index. Is it BODE or BODE?
I think both. I do both.
Okay. The BODE index, which doesn't really help you, it gives you like a 4-year prognostic like idea based on quartiles. I don't find it incredibly helpful. Like, how do you think about prognosis in COPD?
Good question. I mean, I think of it. You've seen everybody that has. I've seen people with the worst lung function you can imagine live for years, and so that's the challenge which we face in putting palliative care to a chronic disease state, is this longer lifetime that they have with way poorer quality of life in many senses than some with advanced cancer. And Amy Kelly put out a great paper that showed that people with COPD have dyspnea, nausea, vomiting, pain, anxiety, all of this often in proportion with advanced cancer. How do you prognosticate? I mean, I think it's an individual level. Without using the scores, we know what the scores can do, but you still kind of sort of paint that picture of the unknown trajectory and raise that up to the patient and just being honest with them about, we don't know that trajectory, but we do know some data. We have some data we can tell you, but you could live a long time. But here's what we do know. Your lung function will decline over your lifespan. You won't be able to walk to the mailbox and back next year. You may not be able to. In 2 years, you might not be able to get out of your house. And so I start painting realistic things. I start drawing in their life space for them and start using that to guide me with their prognosis. So like, what do you want to do? Oh, I just want to get up and down my steps of my apartment. Ooh, okay, we can do that. You want to go walk to your church, which is a mile away? I don't see that happening right yet, unless we do a few things. So I tied into simple stuff.
Yeah, that was a great segment just there. You just highlighted like 3 incredibly important concepts and probably more. 1, acknowledging and normalizing the uncertainty inherent in prognosis for patients with COPD. So much less predictable in terms of mortality than cancer. But nonetheless, there is predictably going to be a loss of function, and that you framed that in terms of what people care about, particularly older adults. How are they going to get around and get out to do the things they enjoy doing, and how is that going to change over time? And that you frame that in terms of the concept of life space, which is a contribution from the from UAB, University of Alabama at Birmingham.
Yep. That's shout out to Richard Allman and Cynthia Brown and Patricia Sawyer, some of the creators of that instrument.
Could you just say a little bit more? Few of our listeners are researchers, but many of them will intuitively grasp this concept of life space. I wanted to just give you an opportunity to get in a soapbox, talk about it a little bit.
Yeah, sure. I've been studying life space and COPD in parallel to this because I think it's just a fascinating concept. Cynthia Brown, Richard Allman were some of my mentors about 15 years ago here at UAB as a young whippersnapper undergrad, studying sort of geriatrics principles here. And life space is your sort of your immediate surroundings. It's the but it's an instrument that was developed here that calculates your distance, your frequency, and independence of movement among 5 life space levels: your rooms and where you sleep, around your house, immediately outside your house, to your neighborhood, and outside your town. And it paints this beautiful picture of how somebody can go from one room all the way outside of their town. And it tracks nicely with numerous outcomes in older adults. In the UAB study of aging, it predicted nursing home admissions, hospitalizations, mortality. So when you say you're restricted in your life space, there's a certain score that will predict with reasonable certainty you can get admitted to a nursing home pretty soon if you're an older adult. And I found that restricted life space in pilot study predicts the COPD exacerbation and tracks nicely with many functional outcomes for COPD patients.
Mm-hmm. And what I like about what you did just there a moment ago was to describe how a person's life space would be impacted by disease progression. In other words, as their disease progresses, their life space is likely going to constrict. And yet, you were finding out what's important to them and aligning those important activities with ways that you might be able to accommodate, help support them to improve their quality of life, which is terrific.
Yeah, we need payer support, though, because imagine something as simple as supplemental oxygen. And you think about a frail, tiny, older female with COPD who weighs 95 pounds, asking her to tote a 5 to 10 pound oxygen tank around. That becomes a tether, right? You guys love the term, I put my geriatrician hat. I've got to figure out a way to get that tether, not to keep her in the house, because she wants to wear her diamond earrings and go to church, and she doesn't want to be kept and use that tether to keep her at home. And I get that all the time. That's a weekly occurrence. This is going to trap me in my home. This is a ball and chain. How am I supposed to tote this thing around? And but if you think about it, they often don't leave their room because of their supplemental oxygen. It's a fall hazard. The tubing goes around the house. They're about to trip all over it, and they can't get it. It's both liberating and trapping at the same time. And so I think of it in a geriatrician's mindset. Oh my God, I got to figure out making sure they don't get stuck at home because of this thing. It's just a simple way.
And you brought up payers and potentially systems factors. I'd love to talk just briefly about the American Journal of Medicine article that you published also on end-of-life spending and healthcare utilization for these COPD patients, older COPD patients. Is it okay if you kind of summarize kind of what you did in that article and what you found?
Yeah, that was a retrospective study of Dartmouth Atlas data and older decedents with COPD. We had 140,000 decedents with COPD older than 65 years. We examined spending and utilization in the last 2 years of life. So these are decedents who died in 2013 to 2014. We looked at overall spending and categorical spending across inpatient and outpatient categories. 40% of the spending came from an inpatient, but the remaining 60% went to all sorts of other ambulatory services. Utilization was through the roof, as you can imagine. Roughly 80% were admitted to the hospital in their last 2 years of life. Half were admitted to an ICU. The length of stay was very high. But what was amazing to me was that as a population health standpoint, there was tremendous variability across the country in ways that different referral regions spent and utilized. I guess it's like if you build it, they will come mentality. Mm-hmm. Highly populated urban centers had high rates of utilization and longer lengths of stay, and those things tracked nicely. But the take home was more so than that was the hospice utilization. We hadn't had any real concrete data on hospice and COPD. I went into this knowing that palliative care was very abysmally utilized. I mean, we're talking 1%. Any study that I read was like 1% of this sample, 1% of that sample. It was a tremendous increase from 0.3 to 0.9%, something like that. That's what I've read over and over and over. I said, well, that's just sad. Yeah. And I knew that the data from things like NHPCO, or Hospice and Palliative Care Organization, was that roughly 50% of older decedents get hospice near the end of life. And we found something similar. About 47% of older COPD decedents received hospice. And though currently, from what I can tell, the average length of stay in hospice is 70 days for the average population, and that's been kind of growing slowly over the last few years. In that time period, ours was 39 days on average. So COPD patients are going real late, and hospice didn't track with spending like all the other categories did.
What do you mean by it didn't track with spending?
It meant that all the other categories, things like acute care length of stay, LTAC length of stay, skilled nursing facilities, all of those had some association. You had more utilization of it, your spending increased. But with hospice, things were pretty flat across the, there wasn't a linear association with spending there. And so my take home was that we were referring too late. There was widely variable geographic utilizations. Some places were super low, some places were decently high. But if we're going to try to make an impact on outcomes like has been shown in cancer, we can't wait till the last month of life to do this. So that's why you need early palliative care.
So what's next for you? So you've taught us that there's high symptom needs, emotional needs, coping needs for individuals with COPD, huge utilization issues, healthcare utilization, that we're not using palliative care early enough. Like, what's next for you?
Oh yeah, that's a great question, and so there's a lot of unknowns in the next few months. But all this data provided tremendous background data for a grant that's out there, and so depending on how that goes, that's where I'm trying to build an intervention, an early palliative care intervention modeled by prior successful early palliative care interventions in cancer, tailored to older adults with COPD, specifically focusing on things like life space and physical function, frailty, those kind of things, and see how this kind of intervention can impact it using a pilot trial mechanism. So that's what I'd like to do, make the career bigger, get the pulmonologist and knock them on the head, tell them we need to do these things more.
That's great. Yeah, teach them what palliative care is. Palli-Palm.
That's exactly right, guys.
It's not hospice. Hey, have you heard of other programs that have Palli-Palm? Are there successful models elsewhere in the country of outpatient palliative care clinics, for example, that are seeing quite a few patients with COPD?
There was one in Canada where they integrated for interstitial lung disease pretty well. They integrated palliative care using nurse practitioners. I've had some colleagues in Illinois and elsewhere embed a palliative care clinician in their pulmonary clinics. Those are reasonable and seem to be scalable options. But I think it's going to have to be that, you guys know this, there's not enough to go around, and we need pulmonologists and primary care clinicians to get the message and learn the skill sets if we're going to have a chance to meet the deficit of palliative care and geriatricians that's coming in the next decade.
Yeah, absolutely. We need models like Enable, which is telephone-based, nurse-led, isn't it? Intervention. We're going to have a podcast with Marie Bakaitis in a month or so.
Yeah, I'm excited about that.
Yeah, learn more about Enable.
You guys. Yeah. That's what my intervention's modeled after, and I know it's sort of preliminarily feasible in patients with COPD. Now we just need to tailor it to the older adult population. But, we just need to make sure that pulmonologists know what palliative care is. That's a big problem.
Well, there's things I think that pulmonologists need to know. I'm wondering, are there a couple things that as geriatricians or as palliative care clinicians that you really wish that we knew? Or pet peeves that you have?
Yeah, this is a tough question. I don't think you guys see enough of them to maybe get the experience. And even in my study, palliative care clinicians were concerned about what medicines like antidepressants and anxiolytics would do to COPD patients. And I think if you gave us a call, we could work together to find a right dose that would be safe. And we've did this discussion throughout this podcast, that opioids are not necessarily harmful, but if you do it at the right right dose, we might be able to work together. Then talking with us about prognostication. I'm one that can bring it up early, but some of my colleagues don't want to refer to you guys because they feel like there's people are throwing in the towel. And I don't think that's right. I think that you're going to have to work with us and figure out what that prognosis means and how do you define that better.
I got another question for you. So I'm really excited about PalliPalm. I want to learn more about it. Actually, we are here at our institution. We're actually working on trying to get palliative care integrated with pulmonary clinic, chest clinic with Neil Trivedi and others like that, and Usher Cotwall from Palliative Care. If I want to kind of dive deeper into this, what can I do to get more involved in the PalliPalm community?
Well, we're on Twitter. That's where we started at PalliPalm, and you could pull up all the hashtags using the model of this famous podcast that I've heard about called Jerry Powell Blog. We're trying to
I heard about that before.
Yeah, we're trying to do this similar model and build that this year. That's the goal for this year, is to start. I thought, I know people across the country and across the world that are interested in this topic. They have to exist. And in the course of 9 months, I found 1,200 people.
Wow.
Whoa.
So this is worldwide. We have people all over India that are tagging hashtag PalliPalm that are like, wait a minute, this is what I do. I'm an interventional pulmonologist. I love